I welcome you all back to the platform today. Um, this is a platform where we discuss issues relating to student support and the placement. Last video talked about the mental health diagnosis, where started with explanation about symptoms and signs of psychosis. So gonna try to do a recap of what we discussed in the last video. We talked about the symptoms and signs of psychosis. We talked about different uh, causes of psychosis. Um, that's where I explained that symptoms is the description of what people say is happening to them. It's a description of what people say is happening to them. And sign is what you can see in people when they present with psychosis. And also explain that psychosis has two causes, organic cause and has a functional cause. Organic cause can be due to some issue with physical health, probably brain injury, probably infection, probably trauma to the brain. So it could be or probably some electrolytes imbalance, and that's what we refer to as organic cause of psychosis. When people present with psychosis based on that. And functional psychosis could be emotional cause of psychosis, probably someone plunged into depression because of social issue, or because of drug-induced drug use, or because of situation, just kind of emotional cause of psychosis. Today, we move forward by discussing the rest of symptoms and signs of psychosis. And if time permits, I will start talking about the mental health diagnosis, different category of diagnosis that you may come across in your placement. So today I will be talking about the thought disorder. Thought disorder is almost the same as disorder of mind, the way people are thinking, disorder of thinking is a thought disorder. So it's also one of a sample of it's one of a sample of symptoms of psychosis, what people describe as what is happening to them. So thought disorder can come in terms of thought insertion. When people think people are putting ideas into their mind, uh, when people think people are putting information in their mind, that's what we call thought insertion. Thought withdrawal could be when people think people are taking information from their mind. People are withdrawing. People are taking the thought. When, like, I give you an example, when you're talking to someone with that person with psychosis, and they start talking and said, "Oh, you exactly what I was about to say is what that person has taken information from my head." So that's what we call a thought withdrawal. Thought broadcast is a thought broadcasting. When people present like that, when they have psychosis, when they think, when they say something, everybody hears about it, everybody knows about it. When that their thought is um, um, being kind of disseminated in terms of broadcasting it. So they have that feeling, and you can present. Well, people can present with that when they are in when they have when they're psychotic. You can see that kind of presentation. Poverty of thought. Poverty of thought come in form of when people are very short of what they want to say, due to the fact that the thought is not coming forward. You see that when you are doing your assessment, when people struggling to put the thought together, and they find difficult to come forth with the information they want to give to you, or that is they're struggling to put their thought together. That is what they call poverty of thought. You see that people that present with psychosis. Pressure of thought can come in form of people trying to say so many things together at one point. The thought is coming, their thinking is faster, and the speed at which they want to say it is also fast. So they want to say so many things within a short period of time, and the things are actually coming together with the speed at which they want to say it, and the thought, the thinking is also coming very fast. You see that people that have that present with a manic episode, they try to pull a lot of things together. They have to try to say a lot of things. People, ideas are coming at the speed at which it's coming so fast. You see that kind of presentation with people that can present with manic episode. Um, and you see poverty of thought, people that have depression. People that have depression, they may come out with a poverty of thought, where they struggle to put their idea together, where they struggle to come forth with what they wanted to say. Other thought disorder could that you can see is the thought block. When people talking to you, but all of a sudden they lose the trend of what they want to say. They just kind of stop, and they couldn't find exactly what they want to say. So when they come back for, they didn't start where they stop. So that is a example of a thought block that you can see when you are assessing a patient with psychosis. People can present with that. So this are the, and we have all we call the reel of thought. The reel of thought is when people come in with different flow of idea. They've not finished one. They've not actually conclude one idea. And they come with another one. Like you can actually observe that when you are having conversation with people that have psychosis, people that present with psychosis. They were trying to explain something to you. They started with one topic, they couldn't finish it, they start another topic, and they are not connected. Those two topics are not connected. That is the real of thought. Their thought is quite derailed. They're not making sense. Their ideas are not connecting. So they don't finish one thought before they go to another one. So that is what they call derail of thought. You can see that in people that come with psychosis as well. So that is examples of thought disorder that people may present with when they have psychosis. And you will see that when you go for assessment, when you go with your clinical assessor to do assessment, you can actually observe this from patients that will have psychosis. And the other symptoms that I've actually discussed in my previous video, that the people can present with that when they are in psychosis, when they present with psychosis. So those are the signs and symptoms that you can see with people that have psychosis. I'm going to be talking now about the mental health diagnosis. I may not finish it in this particular video, or if I don't finish it, I will continue with that in the next video. So I will start with what we refer to as organic. There's organic cause of psychosis, which include symptomatic and mental disorder. Organic, the cause of psychosis could be organic and includes symptomatic mental disorder. This can happen when people have a brain trauma. When people have brain trauma, as probably when there's an accident and people have the suffer brain trauma, they can present with psychosis, and which may probably be organic cause because it's kind of a trauma that causes it. It could be due to degenerative nervous disease. Probably there's a kind of degeneration of the nervous disease, nervous system, that can actually make people to present with psychosis. That will come under organic cause of psychosis. That's we call organic, including symptomatic and mental disorder. It can also present with organic when people have effect of toxic substance in their brain. Effect of toxic substance in their brain. People can present with organic psychosis as well. And a sample of organic cause of psychosis could also be dementing disorder. When people have dementia, probably this kind of degeneration of cognition due to the dying of brain cells, which can lead to different kind of dementia. So people can present with that kind of diagnosis for all that for on the organic causes as well. Memory disorder, delirium, personality disorder due to organic participant, due to organic participant like syphilis, HIV. When people have syphilis or HIV, people can have some personality disorder in terms of how they behave, which can come with kind of psychosis presentation. So it's not that that person actually kind of if that syphilis or HIV is treated, that psychosis will resolve. So that's kind of an organic cause. When people have organic cause of psychosis, when the organic cause is treated, if you are able to treat it, the psychosis will resolve. But in terms of a dementia, it's a progression. So it's the kind of like it's going to progress, it's going to get worse. So that means you can see some presentation of psychosis in people that have dementia. Yeah. So another mental diagnosis that you may come across in your clinical area is a mental and behavioral disorder due to psychoactive substance misuse. I'm going to say that again. Mental and behavioral disorder due to psychoactive substance misuse. This kind of diagnosis is common with people that are abusing substances, psychoactive substances like illicit drug, like cocaine, amphetamine, crystal meth, all these street drug, crack cocaine. So people that are abusing it, like cannabis, people that are abusing this kind of psychoactive substances may present with psychosis. If they stop using it, that kind of psychosis may resolve. But if they continue to use it, it might actually become a resistant kind of issue that they become actually long enduring mental health problem, and therefore under this mental health diagnosis of mental and behavioral disorder due to psychoactive substance misuse. Another diagnosis that you may come across in your placement is what we most of everybody kind of hear about it. You may hear about it even before you started nursing. People talking about, oh, this person has schizophrenia. So it's a popular diagnosis that you may come across in your placement. When they say somebody has schizophrenia, what they're saying is that there's a disorder of thinking. There's something wrong with the way that person is thinking. So that person may come with presentation of paranoia. That person may come with delusional idea. It may come with symptoms of thought disorder. So, but the major thing is that there's a problem with the way that person is thinking. That's where they say the person have a schizophrenia. It's about the issue about the way the person is thinking. Is the thought that is actually a problem. Is the way the person is thinking that is a problem. That's why people that present with this kind of symptoms, they're likely to categorize them under this diagnosis of schizophrenia. That is just the problem with the way the person is thinking. Is the problem with the thought. But when you come across somebody diagnosed with a schizoaffective disorder, I'm going to break down into schizo is the thought, how the person is thinking. Affect is the mood. What is the external manifestation of the feeling of that person? So when there's a problem with the way the person is thinking and the mood, that's when somebody can have a diagnosis of schizoaffective disorder. Schizoaffective disorder. There's a problem with the way the person is thinking, and there's a problem with the mood of this particular person. When these two conditions exist in one person, they can come with this diagnosis of schizoaffective disorder. There's delusional disorder as well. Delusional disorder is about the perception. When there's a problem with the way people perceive things, in terms of there's a problem with the way the person is perceiving things. It's about perception, the sort of perception, the way the person is perceiving things. That's the way you perceive things is there's a problem with it. That's when people diagnosed with delusional disorder. Somebody with delusional disorder may have what we call paranoia, may come with some delusional idea about kind of all this kind of delusional idea that I talked about in my previous video. Delusion of jealous, delusion of religion, delusion of grandeur, and all the rest. So if this persists in one person and is actually consistent, the person may actually fall under the category, under this diagnosis, and they may diagnose someone with a delusional disorder. The next one is going to be a mood disorder. Mood disorder is actually kind of a self-explanatory. There's a disorder of the mood. The mood is actually has a problem. There's nothing about the way the person is thinking, but the mood. The mood can shift. So when the mood can shift from one pillar of being very calm, being very bright in mood, to another pillar of being very low in mood, that is when they refer to that person as a bipolar affective disorder. But before they diagnose somebody of having this condition, it might have a phase of a long period of low mood. You have a phase of long period of low mood, and all of a sudden they switch to a period of manic episode. So they may have a period of probably 6 months of low mood. That time they say they are in the depressive phase. At that time they say they are in depressive phase. So they can now switch. Maybe after 6 months, you can see them presenting in terms of manic presentation. That's they are in a manic episode. So they are in manic episode. So somebody that have this switch of mood from one phase for a very long time to another phase for a very long time, they can fall under the diagnosis of bipolar affective disorder. So we're going to stop here today. I will continue in my next video, but we do normally say at the end of our video that we do this to support our domiciliary care, which is senior bed care. It's a domiciliary care that actually based in Barking and Dagenham. We support people that need home care support. If you have a loved one that actually is struggling to have independent life in terms of deficit in activities of daily living, we are here to support. You can refer us them, or you can actually contact them. We're going to provide them with support. If you have benefited with this video and you think it's something that your colleagues can actually benefit from, you're kind of allowed to share this video so that other people can benefit from it. Your student colleague can actually benefit from it. So in our next video, we'll be talking about we'll continue talking about the diagnosis of mental health, and I will go through the rest of diagnoses that you may come across in your placement area. Thank you for listening.